Alrighty. Hello, everyone. Welcome back to PS Platter. This is going to be a very quick overview slide set talking about diabetes. We're not going to be focusing too much on the condition itself because, again, you've got a really great video coming out about that already. We're instead going to be focusing more on history examination findings, talking about signs and symptoms that you could expect to see, which are really important for your OSCEs, but also for your exam, your written exam, and then finally having a look at some investigations, which they can again give to you in your written exams or ask you to interpret during an OSCE station as well. So without further ado, let's get started. So in terms of history findings, we're going to start off by talking about broadly what we can expect to see. So the first condition we might expect is hyperglycemia. And again, think about why you might get hyperglycemia. It's usually because of uncontrolled diabetes, which means that your the blood sugar levels are just allowed to spike up. And so with hyperglycemia, you might expect to see polyuria or nocturia even, where essentially you're losing a lot more water volume through urine or micturition. And the reason is the concentration of glucose in your bloodstream and therefore in your renal filtrate is going to be much higher. And so it's going to pull out more water with it. And so you're going to have a lot of urine being excreted, and also it's going to be high in glucose, which again is going to be important for some of our investigations later on. You also have polydipsia because, again, if you're losing a lot of water, you're going to have an increased thirst to try and replace that water. So polydipsia referring to an increased thirst. And then you also have fatigue as a result of the diabetes. And you also have infections. Now, infections are because like we said before, there's going to be a lot of glucose in your urine, but you're also going to have that glucose being high in most of your bodily secretions. So that includes in things like sweat, but also in your urinary tract and around your genitals as well. And that means you're more prone or at risk of infections because glucose is a perfect breeding ground for bacteria because it can use that glucose to fuel its growth. And so that's why we have an increased risk of infections, even things like vaginal thrush, which is why you might get recurrent UTIs in these patients. Then you can have hypoglycemic episodes. Now, why might we get hypoglycemia? So you might get hypoglycemia for a simple reason because you haven't eaten enough food, or it might be because with your diabetes medication, you might have taken too much, which resulted in your blood sugar levels dropping too low. So with that effect with the insulin, you might have taken a bit too much insulin. And so your blood sugar levels have dropped below normal levels and you get hypoglycemic. Now with that, just think about the symptoms you'd expect to see from someone who's not eaten for a long time and they're quite hungry, right? They feel a bit faint, dizzy, weak because they haven't really got much blood sugar, but also they're going to feel hungry because the body's going to try and have this psychological drive to get more sugar into the body. And then they're also going to be more irritable and moody because of that hunger and drive to increase their blood sugar. But you also have sympathetic symptoms. And the way I think about this is your body desperately wants sugar and its blood glucose to rise. So it's going to go into sort of fight or flight mode to try and seek out that food. And so you're going to have increased sympathetic symptoms like palpitations and sweating. And you can even get a little bit of nausea and vomiting as well because of that sympathetic overdrive. All right, so complications you might expect to also see are things like the microvascular ones. So you would have covered complications where you have small blood vessels being affected, and that's with retinopathy, nephropathy, and neuropathy. And we'll come to examinations findings for that later on. But retinopathy, you might expect changes like cotton wool spots when you're looking under the fundoscope. With nephropathy, with enough damage, you might expect protein popping up in the urine because of the damage to the glomerular filtration barrier. And then with neuropathy, you can expect signs like reduced sensation in their legs or reduced motor function even. But the most common thing you'll be assessing for an examination is when you look at the lower limbs, you might expect to see that certain dermatomes or certain areas distally don't have very good sensation because of the autonomic, because of the neuropathy. And also with autonomic neuropathy, which I was going to talk about as well, is that if you have a reduction in the autonomic nervous system's ability to innervate different organs, you can have things like postural hypertension, for example, where the person gets a bit faint and dizzy when they stand up, more so than usual, because that autonomic mechanism to regulate blood pressure is lost. You also have macrovascular complications, or things like ischemic heart disease. So people with diabetes are much greater at risk of ischemic heart disease. So it's important that that's monitored and looked after. Peripheral vascular disease. So you might see things like hair loss, and you might see colder peripheries and things like that. We'll come to that more on the examination side of things. Cerebrovascular disease as well. And you also have two, broadly speaking, diabetic emergencies. One is called the hyperglycemic hyperosmolar state, which can even become a coma. And that relates more so to type 2 diabetes, whereas diabetic ketoacidosis is something which relates more to type 1 diabetes. And so what happens in each of them is with the hyperglycemic hyperosmolar state, just think of it as being an exacerbation of your hyperglycemia. So that becomes extremely, extremely bad. And it can even put you into a coma. With diabetic ketoacidosis, what's happening here is that your blood is unable, your body, sorry, is unable to take the glucose in your blood and put it into the cells. And so what happens is the cells are starved of glucose and instead have to start mobilizing fatty acids and turning those into ketones to put into the Krebs cycle and use to create energy. Now, a consequence of that is that you're going to have the ketones in your blood rising because your body is converting those fatty acids into ketones and sending them out to different parts of the body for them to be used. And so you're going to have ketoacidosis because ketones are acidic and they're going to make your blood become acidic. And because you have this acidosis, your body is going to try and compensate to reduce the acidosis. So it doesn't want to make the blood too acidic. And so it will a number of things. One of them is smell breathing, where the person will start hyperventilating. That is basically a respiratory compensatory mechanism, where by doing that, they're breathing off the excess CO2 in their blood and therefore reducing the acidity. They're also going to have a bit of a fruity breath. And the reason is that ketones, as you would have sort of had a look at back in VCE chemistry in the lab, you would have seen that ketones and things like acetone have more of a fruity smell. And that's why the person's breath, if they have a lot of ketones coming out through their breath, it's going to smell a bit more fruity. They're also going to feel dehydrated because, as I said before, with hyperglycemia, you're losing a lot of volume through your urine. So they're going to be dehydrated as well through the polyuria. And they're also going to have a bit of abdominal pain. The mechanism for that is not entirely understood, but it might have something to do with the peritoneum being irritated. And so you can also have nausea and vomiting. But that's diabetic ketoacidosis. In terms of physical examination, general signs you can expect to look out for. On general inspection, you might want to look for insulin injection sites. In terms of vital signs, because we mentioned before, with autonomic neuropathy, you might expect to see things like postural hypertension. So that's important to keep in mind. Another thing which I haven't really included there, but you might want to look out for as well, is a bit of a fever. Because if they're febrile, that might point to an infection, which again, we said people with diabetes are at a greater risk of infection. So it's important to look out for that as well. With upper limbs, you might look for tendon xanthomata because that points towards dyslipidemia, and that is the metabolic syndrome risk factors are important to consider when it comes to type 2 diabetes in particular. Decreased skin turgor because they're going to be dehydrated. So this skin turgor, which you can check by lifting up a part of the skin, will be lost. It won't be as sort of rigid as it normally is. Acanthosis nigricans is another skin change you can see, usually in the axilla, so in the armpits. It's described as sort of a brown velvety skin change in the axilla, and that reflects insulin resistance. So that's more so your type 2 diabetes mellitus. A vitiligo reflects an autoimmune link, which again could be linked to type 1 diabetes mellitus, which is autoimmune. With your head and neck, you can look for a couple of things, but in particular with your eyes, you want to look for a couple of changes that occur with diabetic retinopathy, so cotton wool spots, hemorrhages, microaneurysms, all of which you'll learn more about in your fundoscopy clinical skills, and you'll see images of those as well, which you're expected to be able to point out in written exams and NOSCEs. With the lower limbs, like we said before, because of the neuropathy, you might have decreased sensation. And because of peripheral vascular disease, you can often get some changes like necrobiosis lipoidica. Search that up on the internet. It's a bit of a gruesome image, but I think it's important to know what it looks like because, again, you might get the odd image here and there in your exam. You can also get ulcers, again, reflecting you're more prone to infections, and also hair loss because of peripheral vascular disease, because you have reduced blood flow to your lower limbs and therefore ischemia, resulting in the hair dropping off. Tinea as well, which is again fungal infections, which we talked about why infections are greater of greater importance in a person with diabetes. Investigations wise, so a couple of important things to keep in mind is some investigations to consider for diabetes would be, first of all, at the bedside with the patient, you can just do a quick finger prick blood sugar level. And you'd expect if it's a random blood sugar level, so they haven't really been fasting beforehand, you just take it out of the blue. If it's beyond 11, we consider that to be in the range of diabetes. Whereas if it's a fasting blood sugar level and they've been fasting for a period of time, then if it's above 7, we consider that to be indicating diabetes. You can also do something called an oral glucose tolerance test, where you ask them to essentially drink a very large bottle of glucose solution and then test their blood sugar levels after a given period of time and see if they have a good insulin response and they're able to keep the blood sugar levels within normal baseline ranges. If not, they might indicate again an insulin dysfunction and therefore diabetes. You can also have a look at the HbA1c levels, which typically anything greater than 6.5 is worrying in terms of being important for diabetes. And extra stuff which you'll learn about next year is things like C-peptide. C-peptide is something which is essentially produced with insulin and so reflects endogenous insulin production. And so if it's low, it means you're producing less insulin than normal, and therefore that's sort of more of your type 1 diabetes. Whereas if it's normal or even high, it might be your type 2 diabetes because you're still having normal levels of insulin, but it's just that your tissue is not responding to it as it should be. And then you have an autoimmune screen. So because type 1 diabetes is an autoimmune condition, and it therefore has a greater link to other autoimmune conditions, you can screen for things like celiac and other conditions like Hashimoto's. And there's also another antibody you can screen for type 1, which is the GLP antibody, but that's not too important for you this year. The main thing is the other tests that we've described on here. So if you have any questions, concerns, or feedback about everything we've covered today, please let me know. This is a bit of sort of a quick summary of video tying together what you would have covered in your clinical lectures, as well as in some of the videos that we've already had on diabetes. But let us know if you do have more sort of specific questions, and we can try and answer them either through our CuriousCat or on Messenger. So with that, we'll see you in the next one.